Before starting, just to acknowledge this is a huge team effort. It is challenging to start programs or do something that is sometimes thought to be impossible. So many people, including many of the fellows and residents, have participated in the program development and research, and congratulations to the fellows and residents who graduated last night. Some of them may be a little late because of their late night celebrations. That's okay. So I'm going to start with a few words on palliative radiotherapy and spend most of the talk talking about the role for radiotherapy as an ablative treatment for liver cancer, with the three most common liver cancers, including metastases, being the clinical focus. So palliative radiotherapy is in fact understudied, underused, predominantly due to the fear of liver toxicity from radiotherapy. But in fact, low-dose radiotherapy can be used to treat painful liver cancer from primary cancer or metastases. And fractionations 10 gray and 2 fractions were used in the TROG group, and we looked at 8 gray and 1. Now, despite that, we still don't have many patients referred for this indication. And one of our residents, Hanny Solomon, worked with us to complete a prospective study. And in fact, in this study, we found that approximately 50% of patients had a patient-reported improvement in their pain 1 month following treatment that was clinically significant. And even despite publishing this result and presenting it, there's been a little bit of apprehension about the potential for this kind of simple radiation to help patients. This is one note from a patient. I have to say, sometimes in our field, we get more appreciation in situations when we don't cure patients. And this is a situation where I've had many thank you letters from patients and families regarding the utility of this very simple intervention to help symptoms. So I really believe there's something to this, and hopefully this can be one of the treatments that eventually could be a standard palliative regimen. One of the critiques of our paper is maybe when patients are referred to us, we just provided better, best supportive care and medications. And that's really the background for this phase 3 study led by the NCIC CTG and many co-Is who we work with here. And it's a very simple, small randomized study asking the question, what is the additional benefit of 8 gray and 1 in pain relief for patients with painful liver metastases or liver cancer compared to best supportive care? So all patients have best supportive care and patient-reported pain and quality of life. And 30 days after randomization, half who have radiotherapy and half best supportive care, there's a potential for those who had best supportive care only to cross over to radiotherapy. So everyone has a chance to have radiotherapy, and then 3 months later we have another check in how the patient-reported symptoms are. So hopefully this will continue to accrue. It's open here. It's open in many centers in Ontario. So please think about this if you ever do hear about patients in this situation, because it's actually accruing poorly. And I think we do need to finish this if we want to have an impact on change in practice. So moving to radical radiotherapy. It's challenging to treat liver cancers to ablative doses for many reasons. And one is the potential for toxicity, and one is due to technical challenges that really mandate the need for advanced technologies. This is a list of some of the potential toxicities that can happen. And if you see, I've listed not just grade 3 or 4, but 5. So this is one of the subsites where often there are fatal toxicities reported. And so that balance between enough dose to control tumor, but not too much to cause toxicity, is a fine balance and something that we strive to improve every day. So liver toxicity is something that we have an understanding of in some of its presentations. Classic radiation-induced liver disease, for the large part, can be avoided. But other non-classic radiation-induced liver disease presentations are a little more challenging to prevent, and we're still developing a better understanding of which factors are associated with that. There's no question these toxicities are more common in patients with underlying cirrhosis and primary liver disease. Plus, there's other toxicities to consider to all of the organs in regions in the upper abdomen around tumors, to the biliary tract system in the liver, or luminal GI. So liver toxicity, as I said, is more common in liver cancer and more common in patients who have more impaired baseline liver function, cirrhosis or hepatitis. These are some dose constraints. So for the same volume of liver treated, you can give a higher dose for patients with metastases compared to someone with primary liver cancer, even if there's no known cirrhosis or objective impairment of liver function. And the curve on the bottom shows a difference in the risk of toxicity that is quite a steep slope as the residual volume that is spared from treatment becomes smaller and smaller. And it's not to say that this particular metric is the only metric. In fact, this is a very small study, but it's just the philosophy that subtle differences in the doses delivered to the liver can make a big difference in the risk of toxicity. There's a little bit of pooled analysis. So this is led by the AAPM group, recently presented at ESTRO, looking at different toxicities. So grade 3 liver enzymes are not uncommon. This is a 10% here, so approximately 10% of many of the series have this degree of liver enzyme elevation, more common in series with primary liver cancer, shown in solid compared to the open circle. But grade 2 liver enzymes are seen in about 50% of patients, so very, very common, and appears to be a little bit of a relationship to actually the prescription dose. This is from literature and not pooled actual individual dose volume data. General GI toxicity also can occur. Again, not that common, despite treating patients with very advanced cancers, so about 10% overall. And again, in this analysis, there appears to be an increased risk for those patients who are treated with higher doses. So biliary toxicity is a toxicity that we actually haven't seen very often and is not very well described in the literature. And there's probably several reasons for that. Radiation can cause fibrosis of the biliary system and stenosis that may manifest many years after treatment. Subclinical changes may be missed. Biliary obstruction can present with infection or abscess and may be attributed to other treatments or tumor. The proton series, where there are many long-term survivors, are the first to describe biliary toxicity following radiotherapy at 2 to 4 years after treatment. And more recently now with SBRT, there are several series talking about biliary toxicity. So I do believe this is something that needs to be considered, especially when central lesions adjacent to the biliary tract are treated. So caution with very high doses for central lesions or super hypofractionated rate of therapy. This is one series of 96 patients treated with SBRT, primary and metastases, just showing that 23 of this patients in this cohort had grade 2 or higher hepatobiliary toxicities, 2 with grade 5 biliary toxicities, and a dose recommendation to avoid toxicity. And again, this is probably just one surrogate for high doses to the entire biliary tract are advised. And interesting, when you look a little more detail, this cohort included patients who had liver metastases, no underlying liver disease, who would not be expected to have such toxicity from their tumor progression or underlying liver disease. And so these few toxicities are likely attributable to the radiation treatment directly. And one thing about this series is treatment was delivered largely in higher doses than what we often use in 3 fractions. Again, subtleties that the details matter, a little bit higher biological dose, a little bit more hypofractionation, there's a substantially increased risk of toxicity. So even for luminal GI tissues, there's a higher risk in HCC or primary liver cancer than metastases. Some dose constraints that we use are summarized here. The interfraction interval might matter. Most of our experiences with treatment delivered every other day. Many experiences report daily use of SBRT. And interesting, in the prostate literature, there's a little suggestion that every other day treatment might be associated with less acute and even late toxicity than every day. So for the most part, we use every other day treatment when the luminal GI tissues are dose limiting in our experience. And about 50% of our patients with metastases have dose limited by GI luminal tissues. So this is actually a clinically important issue. And this is rationale for perhaps thinking about other strategies to move the luminal GI tissues away from tumor. And so spacers have been used in prostate cancer to move the rectum away from the prostate, could potentially be used in the upper abdomen to move the small bowel away from the tumor. And this is an example where bowel is adjacent to the tumor. This was provided to me from Ted Hong in Boston, where they use spacers routinely in their proton experience. And by placing the alloderm against the liver, they can move the omentum in the small bowel so that there's a gap of now 2 centimeters. So clearly that's a nice advantage technically, where you can give ablative doses with a low risk of toxicity. So this is one approach, and we haven't done this here. We're looking at cost-effective ways to do this. This approach is quite expensive, done in Boston. So I mentioned the need for advanced technologies. Most of the tumors we see, especially the primary liver cancers, are locally advanced when they're referred to us, with, as I mentioned, a dose that we can give to the tumor limited by the normal tissues. So we need to consider individualized dosing, and this is very common in liver cancer radiotherapy series, very unusual in most other tumors that we treat, and we need to consider strategies to reduce the volume of normal tissues irradiated. One thing that's key in primary liver cancer radiotherapy, but even metastases radiotherapy, is ensuring that we see all the targets. And so diagnostic quality imaging is essential to ensure that we actually hit the targets as planned. And multiphasic imaging is really important to show the disease. So this is an early phase after IV injection where our arterial enhances, portal venous phase about 60 seconds later. It's not so obvious to see the tumor. However, there's a lesion here in the portal vein. And you may say that's all that needs to be treated, but it's really not until the delayed phase is done 3 minutes later that you can see there's a far larger tumor. In fact, much larger than what you might appreciate on one of the other phases, just showing the importance of multi-phasic imaging. And similarly, multimodality imaging, MR, can be helpful in this regard. Breathing motion management is needed. It's very common to have more than a centimeter of motion, and if this isn't addressed, a larger volume of normal tissues are irradiated. Many strategies to reduce breathing motion. We predominantly use breath hold and abdominal compression, but we occasionally consider using lorazepam, which actually can reduce amplitude of motion to a similar magnitude as abdominal compression. And regardless of how breathing motion is dealt with, there's baseline shifts. So the liver and liver tumor position change day to day relative to bony anatomy, really providing strong rationale for daily soft tissue image-guided radiotherapy. And liver image guidance is complex. These are some cone beam CTs from one of our patients treated in 2005. This is perhaps Doug stitched stop and go, one of the first that we did many years ago, not commercially available at that time, but just showing how when you can look at just exhale projections to recreate, you can start to see a little better edge of the liver compared to a free breathing cone beam CT. And finally, the huge benefit of a breath hold cone beam CT, especially in someone who could be treated with breath hold radiotherapy. There are solutions now commercially available, multiple vendors for 3D cone beam CT. It's challenging in upper abdomen, challenging in the liver. Respiratory sorted cone beam CT, I'd say, allows more accuracy, more automated matching. And probably the easiest in terms of matching is breath hold cone beam CT at the unit, which we use commonly. So what is the timeline for using these advanced technologies? Before talking about radiation, in fact, the first ablative or curative therapies used for primary and metastatic liver cancer were used many decades ago. 1949, resection, 1969, transplant, and then non-surgical techniques in the late 1990s and more recently, including radiofrequency ablation or RFA. Most people don't realize, in fact, radiotherapy was used to treat liver cancers very early, in fact, in the 1920s. However, as you know, it's still not standard practice, largely due to the finding of radiation-induced liver disease that was seen when radiation started being used as a curative modality for lymphomas and seminomas and other pediatric tumors. And in fact, that still is a reason I think many are quite nervous to use radiotherapy to treat liver cancers. However, in Michigan, there was an initiative to show that, in fact, just as you can resect tumors, you can deliver ablative doses of radiation safely as long as enough liver parenchyma can be spared from radiation. I was fortunate enough to be there, as Dr. Cummings pointed out, and just looking back at their experience that was started in the 1990s, it was an elegant approach, relatively complex from a patient perspective, BID radiation, 1.5 gray fractions, with hepatic arterial chemotherapy delivered via a brachial artery that had to be, a catheter that had to be put in place. But this philosophy of individualized dose and the possibility to treat these tumors to ablative doses, 90 gray, was shown. And corresponding to that, outcomes were better than expected in patients with metastases and primary liver cancer. with dose response, occasional long-term survivors, but clearly a need to do better. These toxicities that were grade 3 or higher were largely attributable to the catheter and the chemotherapy. And these were predominantly patients without vascular invasion and more early stage than who we see today. So what about liver SBRT? Well, in 1995, the first report came from Sweden about potential for hypofractionation to be used safely. Also in that report was a potential for SBRT to cause toxicity. And then, mostly in Europe, experience started being published. Finally, in 2008, we published our experience in primary liver cancer, followed by metastases, and then much growing experience in North America. And in fact, today, there are more than 2,000 patients from the literature who've been treated with SBRT for liver cancers, more than double that using other techniques. So moving to the individual cancers, hepatocellular carcinoma is a very important cause of cancer death. It's the #1 increasing cause of cancer death in Canada and North America. And although we are making great strides in some of the underlying causes of cirrhosis that lead to liver cancer, prevention of hepatitis B with vaccinations, treatment, and eradication of hepatitis C, it will still be many decades before we see the reduction in HCC from these initiatives. And globally, survival is very poor. It's a challenging disease to treat because there's a cancer that needs to be considered, and the underlying liver disease also needs to be considered, and in some situations may be more life-threatening than the cancer. The most common pattern of recurrence is hepatic and hepatic vascular. So many times we see these tumors invade into the portal vein, the IVC, the hepatic vein. And with extensive invasion into the vascular system, there can be an increase in the portal pressure, and this, in fact, can precipitate liver failure. And so it's a challenge to treat the disease as it invades the vessels. And this is perhaps the strongest adverse prognostic factor in all series. And not only is challenging to treat, but also associated with increased risk of metastatic disease or occult disease within the liver. So unfortunately, radiation is not included in many guidelines, at least not as an ablative treatment in North America, largely in Europe. This is a consensus guideline from Current Oncology looking at the Canadian recommendations from 2011. The tumor stage described by Barcelona Group, or BCLC, is important, but the size, even within stage, is very important for treatment allocation and decision-making. Underlying liver disease, as assessed by the Child-Pugh class, has to be considered with all stages of disease. And as I said, someone who has very poor underlying liver disease may not need any treatment for their cancer due to the poor prognosis of the liver disease. The clinical symptoms matter, the performance status, and at the end here you can see largely patients can be divided into those with the potential for cure, resection, transplant, or ablation, and those with intermediate disease who can have TACE, that's a transarterial chemoembolization, a regional therapy that improves survival but doesn't cure, or Sorafenib for those patients not suitable for other therapies. Unfortunately, radiotherapy is not mentioned in these guidelines, even in the palliative setting, and I think there's probably time now to revise these guidelines in Canada and think about that. Now, not all countries have no absence of radiotherapy mentioned. This is Korean guidelines for treatment of HCC, and in fact, almost a third of the treatment section is allocated to radiotherapy. And on the right, you can see from very early stage to advanced, the highlighted shows where radiation is recommended either as a first or second line treatment. And similarly, in some other Asian countries, radiation is becoming more accepted as a standard of care. So where can radiotherapy fit? Well, for those patients who are potentially curable but unsuitable for standard curative therapies, I think there's a strong role. And this is a patient seen a year and a half ago, written up recently by Aisling Baring and I, who gives this example. So a 78-year-old lady who actually was thought to be resectable, went on to laparotomy, but unfortunately had too much underlying liver disease that wasn't apparent until the time of surgery. Surgery was aborted, but unfortunately the patient had a subsequent decline in their liver function, and even 2 months following the laparotomy had not recovered to be able to have other therapies, so a Child-Pugh B8 function. The tumor was growing, almost 5 centimeters, And we saw this patient and treated with SBRT. This is the plan, relatively simple from a technical perspective. Baseline imaging at 9 months, and she was seen at 12 months following treatment, in fact, with continued improvement of her liver function and no progression of HCC. This isn't just a one-off. There's experience in Korea looking at registry prospectively followed patients, 93 patients, a quarter who have worse liver function as we assess with the Child-Pugh status, Child-Pugh B, modest doses of radiation, and overall, we find that the 3-year local control is excellent, so above 90%. And in fact, 3-year survival, 54%, similar to what we see with some RFA or surgical series. And as I mentioned, a decline in liver function in 10% with occasional fatal toxicity. In a larger series from Japan, very similar outcomes were seen. So again, minority patients had Child-Pugh B, poor liver function, small tumors for the most part, 3-year local control and survival, 91% and 70%, again with occasional serious toxicities. So looking at pooled outcomes, in fact, this is of 431 patients from 5 prospective series. The 3-year local control is 86%, and no dose response was seen between this dose range, so 34 to 54 gray, 3 to 5 fractions, showing sustained local control in the great majority of tumors, different than what we see with liver metastases. Even more interesting, there's now a summary of experiences with radiotherapy where we are actually starting to see thousands of patients. So this is a meta-analysis. It's not an individual patient meta-analysis. It is from literature. But looking at a combination of patients who are treated with radiotherapy, early stage and late stage, with charged particles, stereotactic or conformal. And just to point out, those treated with conformal radiotherapy did have more advanced disease and some more adverse prognostic factors. But looking at this very large experience, we have survival numbers in pooled analysis from now more than a decade. You can see 1-year survival for the charged particles in green, conformal in blue, and stereotactic in yellow. This is actually 100% to 50%. Maybe doesn't display so well, but I think more important from this paper is not the 1-year survival rate, but in fact, the 5-year survival rate from these series. So with particle radiotherapy, pooling all patients, the 5-year survival rate is 37%, SBRT 31%. So again, showing the potential for long-term survival in these patients. Also interesting is to look at the toxicity reported. So a little bit different in patients treated with SBRT or conformal radiotherapy. Higher in the conformal radiotherapy series, probably larger volumes treated, but also, as I mentioned, some more advanced tumors, about 10% in SBRT series in acute and 6% in the late setting. So what about comparison of SBRT to other therapies? Very little comparative data. There's no randomized data at present. This is from University of Michigan, looking over a cohort of time, more than 200 patients who were treated either with radiofrequency ablation or with SBRT, all early stage potential for cure. They had basically, the bottom line is, there are similar patients and similar outcomes. The failure from local progression at 1 and 2 years was similar. So RFA over 80, SBRT a little better at both time points. Overall survival similar, approximately 70%. And toxicity a little less with SBRT. RFA is an invasive procedure where there is a potential for bleeding or infection. Similar outcomes for small tumors, as shown here. And for larger tumors, there is worse local control for RFA. And this is well documented in RFA series. Although we do have some decline in local control, it's less of a factor in HCCs that are larger than 3 to 6 centimeters. So perhaps for the larger tumors, our SBRT should be considered as a first-line standard of care. And we proposed this in that Gray and Brown's article that we wrote several months ago, a little provocative in the absence of level 1 evidence. And just looking at early tumors to consider RFA or SBRT, as tumors are larger, perhaps consider SBRT first. And for those very large tumors unsuitable for RFA or cure, standard of care is still for TACE because it can improve survival, and I think it still is. But I hope in years to come we will have more evidence to help us treat more patients with SBRT and perhaps changing many of these patients from an incurable path to cure. Unfortunately, I do believe that randomized trials in these very early patient cohorts will be very challenging to complete, probably won't be done. So what about the transplant setting? So that's the best treatment for liver cancer. It treats not only the cancer, but the underlying liver disease. Many patients who are thought to be suitable for transplant don't make it to transplant because it's only an option for patients with very small disease. So bridging therapy is sometimes used to try to control the tumor to allow patients to have their transplant, which sometimes can be years after they're listed. So we have looked at this and we have seen necrosis, including complete necrosis at the time of explant from radiotherapy. And using our modest, mostly 6-fraction schedules of SBRT, we haven't seen morbidity at transplant. This has been updated recently, and looking over a cohort of time, patients who had tumors that were growing and at risk of taking a patient off the list, we compared those treated with TACE and SBRT. This is a very advanced HCC cohort. So Milan criteria describe what most transplant series would transplant, and 86% of these tumors had larger tumors or more extensive tumors in this time in Toronto who were listed. So again, the prognostic factors were similar for SBRT and TACE. Dropout was similar, and survival with intent to treat, even including those who are delisted or those who had a transplant, is similar or a little bit better even at certain time points for SBRT. And this is just shown graphically with the 5-year survival after SBRT and transplant of 75%, 69% with TACE. And then those who are transplanted, looking at subsequent recurrence, about 20 to 30% have recurrence, again, similar numbers in SBRT and TACE. So providing some evidence that perhaps we can use radiotherapy as a bridging therapy as long as we don't cause morbidity at the time of transplant. So intermediate stage, is there a role for radiotherapy? So TACE is the standard of care in these patients. This is a series from Korea where patients are treated with TACE. And if TACE is continuing to cause a response, it's a therapy that we use continuously, many months, over years. And that is what was done for the majority of patients. So for those who had a good response, they continued to have TACE with no further therapy. But if there is an incomplete response, then patients were treated in one of 3 arms: no further therapy, curative treatment, so some might have converted to be suitable for RFA or resection, or SBRT. And when you look at the survival of these patients, those who are treated with TACE with good response are shown in the blue curve, the best survival. Those who didn't have a good response to TACE and didn't have any further therapy had far less 5-year survival, although a subset of them are alive at 5 years, 28%. And the 2 middle arms are those patients treated with otherwise curative therapies instead of TACE. So less TACE in radiotherapy in the highlighted red curve, and less TACE, but surgery RFA in the green curve, showing the potential that even with less TACE, that SBRT could improve outcomes. It's not prospective, but in fact, now there's a very similar experience in Europe and in North America. This is an example of similar data from Alabama. So for lesions that are more than 3 centimeters, very similar. Those who had response to TACE, continued response, traditionally have better prognosis in the TACE alone series. Survival is shown here. Those who didn't have complete response and went on to radiotherapy did a little better overall. So I think this is intriguing data enough to suggest we probably could do randomized trials. There are some trials that are in development. A randomized phase 2 trial is going on in Netherlands, accruing slowly. It's for small, large lesions, comparing TACE to SBRT. And in fact, there's a phase 3 study going on in France that is comparing TACE plus or minus SBRT. Again, accruing slowly, but hopefully will finish and help us get evidence in this regard. So what about portal invasion? As I mentioned, this is an adverse factor. It can precipitate liver failure, very challenging presentation, especially when the main veins, the main portal vein, hepatic veins or IVC are involved. Recanalization can be seen after radiotherapy in approximately 50% of patients, 30 to 80% depending on series and the doses and techniques of radiation used. The median time for maximal response is about 6 months, and that's probably the biggest negative problem with radiotherapy, that unfortunately it doesn't cause the disease to shrink immediately. And so a patient has to be controlled from a liver failure perspective until the liver radiation can cause disease to shrink. This is an example of a substantial response of invasion into the IVC and portal vein and a high tumor marker, alpha-fetoprotein. And then 9 months later, in fact, a clinical complete response from radiotherapy with a low tumor marker. And we do see this, but again, most often the response is delayed several months. There's a phase 2 study from Korea, selected patients looking at hepatic arterial chemotherapy with conformal radiation, modest dose, median survival of 13 months. So in the systemic trials, the median survival is in the realm of 5 to 8 months. So a little better than what we would expect. In a larger series of patients, so this is not a prospective study, but a countrywide database of patients with vascular invasion who are treated with radiotherapy, a variety of doses, mostly conformal. About 50% had a partial response, minority a complete response, median survival close to a year. Clearly, those patients who responded did better than those who didn't. And from this, we start to get a glimpse of some of the prognostic factors in this patient cohort. So there's lack of equipoise in Korea of not offering radiotherapy in this group of patients. And I think for those patients who are out 3 to 5 years, I can understand why, but this is the minority. This is the minority. These tend to be patients with good performance status, not main branch, low burden of disease. However, there is a cohort where median survival is in the order of months. And I think there is equipoise in this group of patients, even in the countries with more experience than North America. In our own experience, we had phase 1-2 study, 102 patients with hepatocellular carcinoma. These were patients who were unsuitable for standard curative therapies and standard regional therapies. And actually it was conducted before the time of Sorafenib, so there was no systemic therapies available. So about half, a little more than half of patients had main vascular invasion, that adverse prognostic factor I mentioned, and a minority had extrahepatic disease. These were large tumors, so the combined maximal diameter in the order of 10 centimeters up to 43 centimeters, modest doses, radiation delivered every other day in 6 fractions. This is a kind of response that we're seeing. Unusual to have a complete response, but not unusual to have continued shrinkage for, in fact, months or years after treatment. And the spared liver can, in fact, hypertrophy and regenerate, which is probably important for maintaining liver function after treatment. The 1-year local control, so failure from progression, doesn't mean ablation or cure, but local control, 87%. And in this series, we did see a dose response. In the phase 1 setting, we used lower doses, including 25, 27 gray in 6 fractions. So those tumors that were treated to 30 gray or higher had a lower chance of local recurrence 2 to 3 years later compared to those that had lower doses. But even so, the modest doses controlled the majority of tumors, showing the radiosensitivity of HCC. The median survival was 17 months. And on our multivariate analysis, the 2 main prognostic factors were vascular invasion or thrombosis, as we've described, but a little bit surprising survival by trial. So those patients who were treated in the first cohort, independent of known prognostic factors, did far worse in terms of survival than those who were more recently treated. And median survival in trial 1, 11 months, 25.5 months in the more recent years, with equal numbers of patients with vascular invasion. So what are some possible reasons for this improved outcome? Well, better patient selection for sure. Improved imaging, contouring IGRT. As we know, we've improved things quite substantially over the past decade. I think there's also probably a general learning curve, and it would be nice to tease out which factors are perhaps the most important in this learning curve. Others have seen this too. So this is from China, looking at a group of patients treated with conformal radiotherapy without image guidance or image guidance in IMRT. There's a confounding factor that those who were treated with IMRT had higher doses, but survival, progression-free survival improved, less in-field recurrence, same toxicity. So unfortunately, our treatment is not without some downside, but 30% had a worsening of their underlying liver disease at 3 months, and 7 patients had deaths that were possibly attributable to treatment, as shown here. I think we've learned that you shouldn't treat patients with cancer invading the biliary duct with hypofractionation. This is one of the patients who had a biliary death. This is a patient who had re-radiation, and 5 of the patients who died of liver toxicity did not have any known progression of their disease, and it could have been the treatment that precipitated this. So Mike Velek and Carol Haddad, who was a fellow with us several years ago, have been looking with Tim Craig at ways to describe who this toxicity is most likely in. And in this cohort of patients, looking at the clinical factors, those who do develop toxicity are more likely to have vascular invasion, lower platelets, worse underlying liver function. And looking at the radiation details, you can see the mean doses of radiation delivered to the liver are higher in those patients who had toxicity, a larger potential risk, and larger doses at every phase. So on univariate and multivariate analysis, what are the factors that are important associated with toxicity? In fact, the clinical factors are extremely important. So even the baseline platelet count and Child-Pugh score A5 versus 6, that's still a good category, were important not only in univariate analysis, but also on multivariate analysis. The dosimetry is also very important. So like others have shown, the mean liver dose is important, again, on multivariate analysis. And in addition to that, a D800cc, although I would argue it could be another metric, the early part of the DVH curve is also very important. And when we plot these DVHs, you can see these are the liver minus GTV DVHs for those patients who had no toxicity and those patients that had toxicity. Not apparent at first glance what the differences are, but this early part of the curve, just normalized here for both of the DVHs, you can see that there's higher volumes of lower dose in those patients who tended to have toxicity. And this is something over the years that even without data, we've strived for the same mean dose to spare more liver rather than washing a low dose to the rest of the liver. It probably is important to do that. This is a nice graph provided by Tim Craig. I should mention this is work in development, so we haven't yet submitted this manuscript, but hopefully soon. Mike is finishing it up. So looking at these dose metrics, in fact, no patient who had a mean liver dose of 15 gray or less developed liver toxicity. And so looking at mean liver dose and the dose to the D800cc, you can see there's increasing risk as both of these parameters are increased. And so some guidelines would be to recommend that the mean liver dose be less than 220 gray and the D800 be less than 18 gray. So what about angiogenic blockade in radiotherapy? There's strong rationale. Sorafenib is a standard of care for radiotherapy. Even when we have good local control, the majority of patients with advanced disease develop new lesions. So we need to combine our therapies with systemic or regional therapies. There's some retrospective data published suggesting a benefit to TK inhibitors in radiotherapy, but unfortunately reports of serious toxicity. So there really was a need for phase 1 studies, and we have completed them here. This is one of the case reports showing fatal GI luminal toxicity following 8 gray and 1 in a patient who had sorafenib, one of the earliest reports showing the potential for interaction. And more recently, this is a report of a patient who had an HCC treated with 45 gray and 3, portal vein invasion. Looking at the dose metrics, reasonable. I'd say diaphragm is not something that I was considering as a potential organ at risk, developing our protocols. 3 days before the radiation, sorafenib was held. 1 month after, the sorafenib was restarted. Patient developed skin erythema. And in fact, unfortunately, this patient developed right upper quadrant pain, died, and it was unclear why, because the tumor had responded. And at autopsy, there was fibrosis and necrosis of diaphragm and nerve. So very unusual, but probably due to synergy and just, again, a caution for the interactions to think of toxicities, even that we may not predict. So the 2 phase 1 studies that were done here were in HCC, the SHEP study, and the Metastases called the SLIM study. In the SHEP study, there were 2 strata, so small tumors requiring less than 40% of the liver to be irradiated, larger tumors in 2 cohorts with dose escalation of the drug independently in the same radiation dose allocation that we used in our prior studies over 6 fractions over 2 weeks, with drug started 1 week before the radiation, concurrently following, and then at 1 month following the therapy, standard of care sorafenib was used. So in these dose escalation cohorts, strata 1, very small tumors, we in fact didn't see any dose-limiting toxicity. However, we only accrued 4 patients because we're not, and we still are not, referred these patients for the most part. We see patients with more advanced disease. So hard to say what is the, whether this would be toxicity tolerable or not. It might be. It might be that with low doses, small volumes, irradiated, no luminal GI tissues, it may be tolerable. Strata 2, where this is more typical of the patients we treat, with larger volumes of liver to be irradiated, we did see toxicity. And in the first 2 of 3 evaluable patients in this cohort, there was luminal GI toxicity, GI bleed, and a small bowel obstruction. We didn't see this with radiation alone. And those patients who were treated at a lower level, so we dose de-escalated rather than escalated, again, 1 of that 6 in that cohort that was evaluable developed a tumor rupture, a DLT. And so a signal that there is a potential for increased risk in the HCC patients. The overall survival and progression-free survival was impressive. So in those patients who didn't have toxicity, median survival 26 months, median progression-free survival 12 months, better than what we'd expect. Could be possibly some selection of patients who are eligible for drug and radiation. In liver mets and sorafenib, this is being written up now, there's a slight similar design, although the 2 cohorts were SBRT with up to 80% of liver radiated and whole liver radiation. And the SBRT was similar to our prior experience, the whole liver cohort, 21.6 grains, 6 fractions, to the whole liver, estimated to have less than 5% risk of toxicity. Not a regimen we actually used clinically. Similar design in terms of drug, but drug was stopped at 4 weeks. This was a difficult regimen to deliver. We didn't expect that. So patients with metastases we thought would be able to tolerate sorafenib without cirrhosis. Many of these patients were very heavily pretreated. The whole liver cohort of patients had diffuse metastases. So their underlying tumor may have also reduced their reserve. And at the end of the day, in the SBRT cohort, of 18 patients, there was 1 DLT, and that was actually grade 3 pain that was reversible. So approximately half of these patients were treated to luminal doses that were at tolerance, a little bit higher, in fact, than our SHEP cohort, but we did not see any luminal toxicity, interestingly enough. However, in the whole liver cohort, we did see toxicity. So of 11 patients who were evaluable without progression within 3 months, there were 2 grade 5 fatal liver toxicities. And this is a signal, I think, that this regimen is not worth pursuing with sorafenib in this manner. So there's a poor tolerance of sorafenib and radiotherapy in liver cancers, and the toxicity risk depends on the drug dose, the volume, and also the tumor type, more likely in primary liver cancers. Serious luminal toxicity was seen in the higher volume SBRT series in HCC, and serious hepatic toxicity was seen with whole liver radiotherapy for metastases. We don't recommend this for further study. So perhaps sequential radiotherapy than sorafenib may be safer than concurrent use. And this is a little bit the backbone to our ongoing randomized phase 3 study, our TACE 1112, for patients with locally advanced hepatocellular carcinoma that asks the question, what is the benefit of individualized dose SBRT over sorafenib alone? 368 patients are planning to be accrued. Overall survival is the primary endpoint. We've accrued, I think, patient 81 yesterday. Slowly accruing, about half of the accrual rate we anticipated, 3 to 4 a month. But given that, again, even at ASCO, no earth-shattering changes in standard of care, we hope that we can complete the study. The inclusion criteria shown here. It's not meant for patients who are suitable for standard of care treatment, surgery, resection, RFA, TACE, CHALPU-A patients. However, very large locally advanced tumors are indeed eligible. So up to 20 centimeters, some of diameter, a little bit of extrahepatic disease, a small amount of prior sorafenib, and even main branch portal vein invasions permitted. The dose allocation is shown here, similar to our own experience, but with 5 fractions, SBRT regimen more attractive to our US colleagues, with dose allocated based on mean liver dose. And in fact, in keeping with our analysis of toxicity, I'm happy to say that we didn't find, looking back at our own data, that these were perhaps the wrong mean liver doses. These are perhaps a little conservative, but given the use of sorafenib and radiotherapy, we don't want to see a high signal for toxicity, and we haven't today. So changing gears in the last bit of the talk on other liver cancers, cholangiocarcinoma, tumors of the bile duct, are far less common. It's a more challenging problem, very heterogeneous, whether they present in the liver, at the bifurcation, gallbladder, or extrahepatically. Most experience has been with conventional fractionation and brachytherapy. However, their peripheral intrahepatic cholangiomas could be well suited for SBRT, but I would advise against hyperfractionation in the extrahepatic lesions close to duodenum, where there's the potential that the biliary toxicity could lead to downstream problems in the biliary tract. In our own experience, we did include intrahepatic cholangiocarcinomas in our SBRT series. Of these 10 patients, we saw acute toxicities, biliary obstruction, cholangitis, and 2 who had decline in score at 3 months. I'm not going to show subsequent SBRT series, but there have been many other small series with far worse survival and higher rates of cholangitis that can be fatal. So it's a much more challenging situation to treat with hypofractionation. Now, interestingly, in the past year, there's experience from MD Anderson and Mass General looking at conventional fractionation and more modestly hypofractionated 5-fraction regimen. So this is a retrospective study of 79 inoperable intrahepatic cholangio patients. Many had no positive, minority had metastatic disease. There was this integrated boost technique with 45 gray in conventional fractionation covering PTV, but up to 100 gray in the GTV. And looking at these outcomes, they are very impressive. So local control and survival are strongly affected by the doses delivered. And so you can see 3-year local control at 78% versus 45%, median survival not yet reached, with a cohort of patients who have surviving more than 2-3 years. So the caveat is this is retrospective. Clearly there's going to be some selection for patients who may travel to these centers. But when you do look, this isn't statistically sound, but just as a comparison, how do these patients fare with standard of care? Standard of care is gemcitabine cisplatin in these patients. And the median, the curve from trials is shown here, that in fact it's not just a subtle improvement even in the lower dose arm. These patients did far, far better. So I think, again, a strong signal that radiation can be useful, but in a more uncommon cancer, how can we provide evidence to change practice? It's challenging. Very shortly after the retrospective study was reported, a prospective study of 15-fraction proton therapy by the same group was reported. So this included patients with HCC and intrahepatic cholangiocarcinoma, some with poor underlying liver function, median size 5 centimeters, vascular invasion in 30%, perhaps a little smaller than in our own cohort. And so doses on the median of 58 gray and 15 fractions were used, maximal dose up to 68 gray. It was individualized dosing, same philosophy as what we use for SBRT. And local control at 2 years was excellent, so above 90% for both HCC and intrahepatic cholangiocarcinoma. Overall survival in the prospective series, a little worse than the retrospective series, but still better than any systemic or other cohort for similar patients. So this is really the background between a study that has been launched in NRG. So it is another phase 3 study. It's asking the question in the same cohort of patients, how does the addition of 15-fraction conformal radiotherapy, photons or protons, improve survival compared to gemcitabine and cisplatin in these patients? Unfortunately, despite this trial opening for several years, there were 0 patients accrued. This is a very common cancer. I think there's lack of equipoise and it's hard to accrue to a non-radiotherapy study. It actually is now being amended. There's some changes that are happening. It is not, it probably will relaunch, but I think even with amendments, it's going to be very challenging to complete the study and change practice. So on the final clinical situation I'll discuss is liver metastases. So colorectal liver metastases surgery is standard of care. And just looking at a series from 1990 for patients who had unresectable disease, this is before modern chemo, median survival 7 months, resectable but not resected, median survival about double. And those who were resected with negative margins, again, double, 30 months. So an older cohort where this is probably predominantly due to surgery. In modern series, 5-year survival rates are from 50 to 60%, even though more patients with more adverse prognostic factors are included. But of these patients, about 60% have progression. So the minority are actually cured. And these are the patients that maybe non-surgical therapies such as SBRT may benefit. And when we look at patients who had initially unresectable colorectal liver metastases, this is a very common group where we see and have excellent responses to modern chemotherapy that's improved substantially, Overall survival rates can be as high as 46% for R0 resection, but much worse in those patients who never go to resection. And if you look more closely, even fewer of these patients are cured. So majority of these patients do have progression. And so although we see these in our tumor board and we do more and more surgery in more and more patients, it is the great minority who have initially unresectable who are cured with subsequent surgery. Perhaps more of a role of non-invasive therapy should be taken. There's a randomized study, not yet in manuscript form, asking the question, what is the addition of RFA to chemotherapy in liver metastases? And in fact, has shown an improvement in not only progression-free survival, overall survival. Probably the only level 1 evidence we'll have for local therapy in colorectal cancer. So as I mentioned, there's rationale for SBRT. The advances with chemo are largely in first-line systemic therapy, so perhaps it's after first line where we should be asking the question of how our local therapies can improve outcome. And very importantly, I think survival is not the only outcome of interest. Time off chemo, quality of life, cost-adjusted quality of life are relevant endpoints for our patients. So looking quickly at the prospective studies that were first published, they're small. They include multiple different tumor sites. And we still, even in the surgical literature, do not have the kind of evidence I showed for the benefit of surgery. So much more difficult to know how to select patients with non-colorectal liver metastases for treatment. So in these cohort of patients, local control is seen in the majority of tumors. Again, a mixed cohort of patients, meaning survival improving, probably selection. And unlike HCCs, these patients do need, in general, to have higher doses. So there is a local control effect with SBRT from pooled analysis. In our own initial experience of 68 patients, the majority with colorectal, these again were large tumors treated with 6-fraction SBRT. There's no grade 3 or 4 liver toxicity. And in fact, we've treated many more patients now, and Ashley Baring is looking at the outcomes of these patients in terms of lack of toxicity and describing the grade 1 or 2 toxicities and if there are factors associated. But for the most part, very different than primary liver cancer, we can do this kind of radiotherapy safely. The majority of the responses are sustained. And looking at our original survival, you can see here, the median survival is shown. And on a very nice note, in a phase 1 study, we do have patients out 5 to 10 years who've had no other progression, no other disease, who maybe are cured from their cancer with colorectal or breast metastases. Prognostic factors, extrahepatic disease associated with survival, and for local control, the dose is important, and the tumor site is very, very important. So in fact, you need higher doses to treat colorectal cancer than breast cancer metastasized to the liver. How much doses is needed? This is work done with Anand Swamanath, a prior fellow, and Mike Velek and Christy Brock. In fact, when we look at dose accumulation, using deformable image registration, there's a larger spread of the tumor doses associated with local control, a steeper hazard ratio, showing the potential of dose accumulation to help us better understand what doses are needed. So far better outcomes when 46 grains, 6 fractions were delivered. And interestingly, looking at colorectal alone, this is unpublished. Andy McPartin is looking at this. Our outcomes for colorectal liver metastases, I'd say, are poor, not good enough. And from this, with these doses used, the minority of patients are actually controlled 3 years after their treatment. And the dose makes a big difference. So when we can give a 38, 45 grain, more likely a chance of sustained control. And looking at the prognostic factors, there are some patients who are long-term survivors and some who survive less, again, giving us a glimmer of perhaps how to better select patients and not to use SBRT if we can't give high enough doses that are likely to cause sustained control. We've done a pooled analysis of colorectal cancers, and in this analysis, the doses estimated to be associated with 90% control are 50 gray in 3 fractions, so far higher than what we need for HCC. Others have looked at prognostic factors in cohorts, not prospective, but large cohorts. Again, a mixed tumor type, although the majority had colorectal. And in fact, this is oligomets, not only from liver, but from lung. Again, a selection of patients with good performance status who may live without disease for many years. So typical patients, this is a young patient who's refractory to all standard therapies with liver-only metastases. treated with 45 gray in 5 fractions. I didn't show mutation status, but KRAS mutant and many mutations. So although we did have local control for some time in the liver, this patient ultimately did recur outside of the liver, but in fact said the best time since his diagnosis was those 2 years without systemic therapy. More commonly, we see patients who maybe have better biology, maybe not the same mutations, but aren't eligible for standard therapy. So elderly patient population, someone who had RFA for many years, but tumor came back, treated with 50 gray 5 fractions, 3 years later, no recurrence. So winding down to who are the patients that we should treat, there's some factors from safety that we can think about, and from efficacy that I've presented, and for some subtypes, if we can give enough dose, we're far likely to control tumor better. But I'd say this is our biggest challenge, selecting who with metastases to treat. We can do imaging to rule out diffuse extrahepatic disease with PET. We can do Primivis contrast agent, MR, to rule out small diffuse metastases in the liver. Natural history is important, but I think in the clinic, clinical trial, this is the biggest challenge we have, knowing who to treat and who not to. So there's a very strong need for biomarkers. And I'll just put a plug for the program, the Radionics, call for grant submissions. I think it's still open. And biomarkers can help for treatment selection, who's more likely to recur locally, who's likely to have occult diffuse disease, who's oligometastatic, who's more likely to respond to radiation, and for toxicity avoidance. We're doing this work now. It's too preliminary in some of our liver cancer patients treated on trial. And the liver has something a little bit interesting about it in that it's a metabolic factory making protons, so metabolomics may be an interesting biomarker, especially for toxicity, so we're starting to look at that. So in conclusion, SBRT can ablate liver mets and HCC. The risks are lower in liver mets. We perhaps should be using longer fractionations for cholangiocarcinomas. Is liver radiation ready for prime time? I'd say yes, but in selected cases. And clearly there still is a need for completing randomized trials if we're going to change practice and help more patients, not just in selected institutions, but around the world. And so we need support of these trials. And these trials won't only provide evidence for the benefits and toxicities of treatment, but I think are improving the quality of radiotherapy delivery in all those who are credentialed. So I'll just wind down again by thanking many people who've been involved in many aspects of this program, and I'm happy to take a question or two. Thank you.